Assalamu alaikum. I'm not sure I can get through this complicated discussion in like 2 minutes, but I'll try my best. I don't have any financial disclosures. This is the outline of my presentation. CAD is very common in TAVR population. The earlier trials, obviously, they were higher risk. So the CAD prevalence was very high, up to 80%. As we went and did TAVR on lower risk patients, it's gotten down into the 20% range. Since our talk is about the left main in TAVR population is about 11%. There's about a 50% chance of having an LAD if you are working up somebody for TAVR. CAD is also not just important before TAVR, but it's also very important after TAVR, because if you put especially a long frame TAVR valve, sometimes it's extremely difficult to actually revascularize these patients. And if you think about how we handled CAD in TAVR population, early on in the game, we were mimicking CABG. We were treating every lesion that was more than 50%. Our thinking has evolved using functional revascularization. We treat only the ischemic lesions. And in the recent 5 years, we're only treating proximal severe or even symptomatic severe. And there's a lot of trials ongoing right now. So we have some dilemmas to answer. Number one, do we need to routinely revascularize patients with CAD before TAVR? And if yes, do we do it before, during, or after? And obviously we're focusing on left main in this population, but we all know that trials that included left main patients for medical therapy versus PCI is very lacking. Normally, most of the trials will exclude left main patients. And this is, for example, a case. This is a patient who has very severe eccentric left main lesion, elderly patient who is going for, the heart team decided to go for TAVR. They also have severe aortic stenosis. How would you approach this patient? We all want data, obviously, and as we talked about, there's only few RCTs that have randomized left main patients in severe aortic stenosis. And the one in 2021 is the last one on the slide. It's called Activation Trial. Very small trial, 230 patients. They randomized patients into PCI before the TAVR, and the other arm was no PCI, and they included left main, but they were only few patients. I will show you the exact number. The complete TAVR trial, which personally I was a part of before I moved to Qatar in the US, they are planning 4,000 patients, and they do not have any exclusion for left main. I personally have randomized patients with left main disease into this trial. And the recently published trial, which you probably are aware of, is the Notion 3 trial, randomizing patients with severe aortic stenosis into PCI at any time versus medical therapy. They have excluded left main. So the activation trial, if you look, there's only 9 total patients that have left main. So really it's very hard to make any conclusions regarding left main and TAVR from this population. But if you just take this with a grain of salt, there is really no difference in death and rehospitalizations if you do PCI versus medical therapy, provided that you're doing the TAVR. And there was a lot more bleeding in PCI arm, obviously, because of the dual antiplatelet therapy. So the Notion 3 trial obviously did not include left main, but the important part about this is 75% of patients got the PCI before the TAVR. And PCI was associated with a lower risk of MI and urgent revasc than conservative treatment. So usually when we have left main and TAVR, we think, okay, before, during TAVR, and there's pros and cons to every approach. Before TAVR, obviously there's easier coronary access. There's a lower risk of coronary events during the TAVR. That's a theoretical risk. It's not been proven by any trial. This option might be the only option if you have somebody who presented to the hospital with severe AS and shock and left main. The cons, there's a lot of cons to do in PCI of left main before TAVR. Risk of hemodynamic collapse is very high, especially with very critical aortic stenosis. You might need mechanical support plus minus aortic valvuloplasty. You might need 2 separate large bore access. And is your physiologic assessment reliable in the presence of severe aortic stenosis? We all know IFR and FFR. There's a lot of trials thinking about whether it's actually reliable. During TAVR, obviously you have access, so you can do it. It's easy coronary access. It's one-stop shop. The cons, you're going to use more contrast, longer procedure time. In the US, it's very hard to do because reimbursement is an issue. You'll be reimbursed only for one procedure. The Middle East is probably a little easier to do. After TAVR, which is probably most reliable physiologic assessment, lower risk of collapse during the PCI because you fix the aortic stenosis. There's some data to suggest reduced risk of stroke if you have done the TAVR first. The cons, difficult coronary access, especially if you're using Medtronic valves or Evolut or toll valves. There's a theoretical risk of MI between the TAVR and the PCI session. And that particular patient that I showed you the angiogram to was in the hospital with shock, so we elected to do the PCI before the TAVR, and we had to do a BAV and Impella guided PCI, and TAVR was done afterwards. I'm trying to move fast to respect the live session, and this video is not playing, but anyways, the left main was fixed. So in summary, currently we don't have any large randomized trials to inform PCI practices in patients with left main CAD who are going for TAVR. Obviously, the entire session was focused whether we should do PCI versus CABG. In this particular population, we have decided to go for TAVR, so it's kind of an easier decision because we're going for PCI because nobody's going to leave left main for medical therapy. There's a large practice variation all over the world. My practice in the US in the last 4 years is I do the TAVR first, and I then do the PCI. And I've even randomized patients into the complete TAVR trial with that approach. And I yet to see a patient who does not do well with TAVR, even if they have left main. In fact, I have a patient who I've done TAVR for. They have osteal left main, severe osteal left main disease, and osteal severe RCA disease. And they've done really well with the TAVR. And we brought them back for PCI afterwards. It is incredible how patients tolerate pacing and TAVR when they have CAD. More and more centers are comfortable doing PCI after TAVR, although the trend in the past, as Notion 3 suggested, that was 75% of them was before the TAVR. Concomitant TAVR and PCI might be feasible in some parts of the world with no reimbursement issues. We are eagerly awaiting the 4,000 patient trial, complete TAVR, which is having a lot of hard time enrolling in the United States because people have fixation biases to what they want to do, and they're having a hard time believing that they could randomize a patient with CAD to do the TAVR first and then the PCI. And thank you. Open to any questions.